We're here at the EuroMigos annual meeting in Nashville talking about some really exciting ESMO updates in the space of bladder cancer. I'm Karine Tawagi. I'm a genitourinary medical oncologist at the University of Illinois in Chicago, and I'm pleased to be here with two of my friends and colleagues to talk about some updates in bladder cancer.
Dr. Koshkin?
Yeah, I'll go first. So Vadim Koshkin, I'm a GU medical oncologist at the University of California, San Francisco, and an associate professor there. I focus in bladder cancer. I help co-lead our bladder cancer clinical program from the medical oncology.
And I'm very excited to be here, Dr. Tawagi, Dr. Koshkin. I'm Petros Grivas. I'm a medical oncologist in Seattle. I'm a professor and serving as the clinical director of the GU Cancers program at the University of Washington and Fred Hutchinson Cancer Center.
Wonderful.
Excited to be here.
Well, we're excited for some updates and some discussions later at the EuroMigos meeting, but first we want to talk about some updates that we've seen at ESMO and kind of where the practice has been changing in terms of non-muscle invasive bladder cancer. So we did see a couple updates in this past year. Would one of you want to maybe elaborate on some exciting updates in the field of non-muscle invasive?
I can start and Vadim can comment. So non-muscle invasive bladder cancer is such a huge development of new trials. It is actually unprecedented time, right, to have all these trials, especially with BCG unresponsive high-risk non-muscle invasive bladder cancer. It's really interesting to see that because, over the years there was a stagnancy of options. So we have seen data with Sunrise-1 at ESMO in previous meetings, AUA and other meetings. So Sunrise program evaluates the role of the TAR-200, which is this pretzel that is given intravesically by urologists once every 3 weeks. And that pretzel is a device that is impregnated with gemcitabine chemotherapeutic that is being diffused, let's say, and delivered intraluminally into the bladder wall. And the data so far with this device, the TAR-200 given every 3 weeks in the Sunrise-1 data as monotherapy, in BCG unresponsive NMIBC is pretty compelling, higher than 80% clinical complete response rates, especially early on. The big question, of course, is durability of that response beyond a year. The data look compelling. This device is not approved yet, but I think it's under review by the regulatory agencies, and I think it will be interesting to see what the data show with longer follow-up. Vadim?
Yeah. No, I think we'll echo what you just said. Until just really just a few years ago, we had only just a couple of options, right? For patients with non-muscle invasive disease would get BCG. Then if they progress, then it's really, us and our urology colleagues are really having the, radical cystectomy talk with them, right? That this big surgery is coming up next. Then actually pembrolizumab was approved as systemic therapy, but it is systemic therapy. So now it's great actually to have a lot of these intravesical options come up as well, right? There are a few others also, recent approvals like IL-15, and now this, the Sunrise program I think has been really, really interesting and really a new way, of course, to deliver chemotherapy that's potentially, not just chemotherapy, actually targeted agents as well, right? There was other trials also, and it's, potentially would be transformative in this space also, right? And provide additional option for patients in non-muscle invasive disease and also actually in muscle invasive disease where there are some trials now as well.
Yeah, absolutely. I think, one of the things with non-muscle invasive is giving 2 years of IV systemic pembrolizumab may come with lifelong toxicities. So having these intravesical options that have more localized side effects is a great option for patients. But of course, we need to see what the durability is going to be from these trials. So I think it's an exciting realm of a new world in non-muscle invasive bladder cancer and in muscle invasive bladder cancer, as you mentioned. So I would love to pivot and talk a little bit about Sunrise-4 since we're on the topic of pretzel devices.
Very interesting, and as Vadim said, with these advancements in non-muscle invasive disease, we can use the same platform and think about the potential impact on muscle invasive bladder cancer. So Sunrise-4 was a study, is actually an ongoing study. We have it open at UW Fred Hutch, and this is a randomized study when you have the sertralimab, a checkpoint inhibitor systemically administered, plus minus the TAR-200, that same device given intravesically with gemcitabine intraluminally. And the data we saw, it was not final data, of course, it was the early cut, preliminary data that was presented by Dr. Necki and Dr. Sutka at ESMO. We saw an interesting pathologic complete response of 42% with the combination, which is interesting to me. that you have cisplatin-ineligible patients, or those who refuse cisplatin. So this was specifically for these patients, cisplatin-ineligible, or refusing 42% PathCR8 without giving systemic chemotherapy. A compelling result. Of course, it's not final result. The trial is still ongoing, accruing. We have to see, of course, the durability of this benefit. Again, PathCR is a reasonable endpoint in those phase 2 trials, give you a signal of go, no go decisions, but I would like to see durability and event-free survival eventually. And the question is, how does this fit in the context of other trials in this disease? That will be the challenge, I think.
Yeah. Yeah, I also just want to highlight this is a very important space, right? The patients who are ineligible for cisplatin-based chemotherapy because there's for muscle-invasive disease, because there's really right now no really standard of care for them in terms of any sort of systemic options, right? We basically take them to radical cystectomy, but of course we want to prioritize clinical trials like this, and there are also a number of trials with, well, Sunrise 4 is one. There are trials of systemic agents that we'll also, of course, discuss. So this space, I think, will be transformed over the next several years. But yeah, I mean, the Sunrise 4 data I thought was very encouraging. You know, as you mentioned, the complete response rates of just over 40% with the combination, and then downstaging. So what maybe you would consider a partial response in this setting of, I believe, over 60%. So really, I mean, most patients, again, in this very challenging population, actually benefit from this, which is, I think, very encouraging. You know, what I do wonder, and maybe I'll pose this question as well, is, you know, so for muscle-invasive disease, we really want to make sure to, you know, potentially control micrometastases as well, right? So that's the importance of having systemic therapy and not just the intravesical delivery of whatever drug you're giving. So in a trial like Sunrise 4, patients get citrilimab. Is that enough in that sort of situation, especially as we have upcoming trials with you know, EV-pembro combination, of course, the chemotherapy combinations, things like that?
And I think this is a great question. You know, the challenge we have in this disease and overall is lack of predictive biomarkers who can help us select patients who may benefit from treatment A or treatment B. And obviously, you know, we have multiple different, you know, regimens being tested in clinical trials. The pathologic downstaging is I think, very interesting marker and metric, especially in phase 2 trials. But the question is, how does this translate to long-term survival benefit? Especially if we don't have an adequately powered randomized trial, it's hard to tease out that question. So I think it's a very encouraging data, both in terms of the PathCR downstaging and, of course, the question that Vadim pointed out, you know, can systemic checkpoint inhibitor by itself add value in cisplatin-ineligible patients? Probably not, because these PathCR8s seems to be, in my opinion, so far, not higher compared to what we see with chemotherapy. And I think in the context of pembrolizumab and enfortumab trials that are coming, or the VOLCA trial with durvalumab plus minus tremi plus enfortumab, those trials are more likely to provide some very, very potentially high pathologic CR8s and long-term survival. So I think cisplatin-ineligible setting, I think the EV-pembro Keynote 905 and the VOLCA trial are going to impact the future, probably when the data come, of course.
Yeah, absolutely. And I thought one other interesting thing with Sunrise 4 was that there was a slightly higher response in those that had incomplete TURBT. I don't know if you have any thoughts about that. And just one point, you know, we're talking about predictive biomarkers and people are getting systemic therapy. I think it's still really important for us to pay attention to these long-term immune-related adverse events. I know there was one death on the citrilimab arm from hyperosmolar hyperglycemic coma, so I think that we still want to be very mindful in terms of giving people benign therapies, you know, that could potentially have long-term consequences.
That's a great point, and I think all of us are always making an effort to educate the patients about the risk of immune-related adverse events. It's a very important reminder, Karine, as you pointed out, to have this education. And even when the patients go home and after treatment, we give them these cards or written information like pamphlets that if they have any side effects, to call us immediately, number one, and number two, if they go to any local emergency room or local, you know, provider, to show them that they're on immunotherapy, so they have full awareness of what that treatment is and what the potential immune-related adverse events can be. And I think that's a very important point that you raise.
you.